Following that, thank you so much, Amy. That was beautiful and so well said and so important. I think I'm going to build on a theme that Amy introduced, although I wasn't quite planning on it exactly this way, which is that it's obvious that Amy has found a way to unify her professional life and her personal life in a very powerful way that influences others. And I've had that same experience of my personal life and my professional life kind of coming together in a surprising and unusual way. And so over a 4-year period, I lost 3 members of my family: my father, my mother, and my brother. And in each case, Amy, you'll be happy to know, they were able to express their beliefs, wishes, and preferences, and the healthcare system met them. And that was such an important and reassuring and really empowering experience for them and for our family and their friends and other loved ones. I don't have time to tell all the stories, but I'm just going to touch briefly on the story of my father, who was in his early 90s and led an active life and had been committed to social justice his whole life. And he had congestive heart failure, and his life began to slow. And he had the normal kind of interventional medical team. And I sat down with him and his wife and said, maybe now time to talk about hospice. And of course, they had the traditional view of hospice, which was when you were just going to be helped to die, which is, as you all know, not really the goal or the purpose of hospice or palliative care. But we started that, and when we had that kind of meeting with the social workers and the hospice caregivers, at one point my father said, "Can we move this along?" And it wasn't that he didn't want to move the discussion along. He wanted to move actually his life along. He wanted a Niagara Falls as well. It turns out he had a pacemaker. And the medical director of the hospice said, well, you could have your pacemaker deactivated. And although his cardiologist and his electrophysiologist had never done that, had never heard of it, there turns out there were well-established national guidelines on how and when and the kind of ethical issues of doing that. And after a lot of consultation with some ethics committees at the hospital and with the family, in fact, that was exactly what happened. And on the last day of his life, he woke up. He was helped downstairs. He was living at home with a little help. He came downstairs and he had a little breakfast. He looked at the newspaper. He may have even done a little of the New York Times crossword puzzle, which was one of his favorite things to do. And then he went back upstairs, was given a little medication to help him, and the electrophysiologist came over with a laptop and just entered a few keystrokes. And that shut his pacemaker down. And he died, as predicted, about 12 hours later, with his grandchildren singing to him and his children surrounding him and his wife kind of hugging him in his bed. And it was a beautiful, sad, but beautiful end. Now, at the same time this was going on, and my mother, who had cancer, and my brother, who had end-stage renal disease, each different medical diagnosis, each had a kind of comparable experience, not as dramatic in some ways as my father's, but very similar. Well, during this time period, I was serving, as I still do, on the advisory board of Ariadne Labs, an organization that probably only a few of you know about, but this is the program founded by the author and surgeon Atul Gawande that works on improving care during childbirth surgery and end of life. And I had just been sitting in a policy and meeting with Atul and heard the results of a study that had just been conducted at the Dana-Farber, and they were striking. That patients who had, so Ariadne has a training program that they developed, which has some of the components you would imagine, coaching for clinicians, a system for documenting a patient's goals and preferences, and a conversation guide that helps facilitate the dialogue. And I listened to the results of their study, and it was striking. Patients under the care of physicians trained in the Ariadne program had earlier and more frequent conversations with their doctors, reported less anxiety and depression, And the family members generally reported a better outcome. So I heard the echoes of my personal experience. But especially important that Ariadne was gathering the empirical evidence to support this more innovative approach to care for those with serious illness. So I came back to my job as the CEO of a large health plan in Massachusetts, and I convened our physicians and nurses and reimbursement experts and program experts, and I said, 2 questions. One, how can we spread this kind of innovative work that Ariadne is doing? And what could we do as an insurance plan to improve care for our own members when they were facing a serious illness? And we had good reasons for addressing this issue. We already had developed a very close relationship with the physicians and hospitals in Massachusetts because, as some of you may know, we are the plan that really has pioneered a new model of payment to move away from fee-for-service towards what we call global payments with quality incentives. And so we're moving away from individual procedures and interventions and focusing more on population health, quality, and outcomes. And so why not apply some of those ideas to serious illness? So that team came back with a series of recommendations. And as a result of that, we've changed a lot of our approach to our members with serious illness. So we expanded payment for the conversations between members and their clinicians around advanced care planning, including not just medical professionals, but also mental health professionals, psychiatrists, psychologists, and social workers, who sometimes may be better positioned to have these conversations than physicians. We increased education and training on how to prepare for advanced illness for our members, their families, and their clinicians. We expanded our benefit to hospice from 6 months to 12 months and eliminated that federal rule where you have to choose between curative treatment and palliative support. We began to sponsor and support our physicians who are being trained in the Ariadne program. And finally, we said, as a health plan, we, of course, promote wellness with our employees, and we give them credit for joining a gym and for doing health screenings. Well, now we've added to that list being trained and thinking about advanced care planning. That, too, is a part of wellness, and we're joined in that work with our great partners from the Conversation Project and from Honoring Choices, Massachusetts. But as important as that work was, and as excited as I am about that work, I looked around and I started to, as I became more familiar with these local organizations in Massachusetts, like the Conversation Project and others, and like the great work that was going on at the Farber, at Mass General with Vicki Jackson, and among other kind of centers of excellence in Massachusetts, I realized there was no statewide focus or forum or initiative to do this work, and that it was one thing for us to support our members in Massachusetts, but we are here on behalf of the whole community, and what could we do for the whole community? And so with a couple of these leading organizations, we formed a new coalition, the Massachusetts Coalition for Serious Illness Care. And the group includes individuals and organizations representing physicians, nurses, hospice workers, bereavement counselors, clergy, hospital and health plan administrators, social workers, attorneys, policymakers, researchers, and other health professionals. We have a kind of simple goal, but an ambitious one, to ensure that health care for everyone in Massachusetts is in accordance with their goals, values, and preferences at all stages of life and in all steps of their care. We've established some important measurable and near-term goals, that everyone aged 18 or older in Massachusetts has designated a healthcare decision maker or agent, that everyone in Massachusetts 18 or older has had a conversation and continues to have the conversations with their agent to communicate their goals, values, and preferences for care at the end of life, that all clinicians in Massachusetts have the training to facilitate these kind of conversations on advanced care planning, that everyone in Massachusetts facing a serious illness has had a high-quality, informed goals and value conversation with their care team, that all providers in Massachusetts have in place systems to elicit and document these goals, values, and preference for their patients. And then again, that all Massachusetts providers have systems in place to share those goals, values, and preferences across care settings, which often is a missing link in these systems. So with those goals, we set about to actually test where is the Massachusetts public on these issues. And so with the collaboration of University of Massachusetts, we conducted a survey of the public here, and the results are going to echo what you heard from Amy. 85% of the state's residents believe that doctors should discuss end-of-life matters with their patients, yet only 15% have. More than half of the residents have not named a healthcare agent. Men, non-whites, and non-college educated people in Massachusetts were significantly less likely to have named an agent and significantly less satisfied with the care of a loved one. So we have a lot of work to do in Massachusetts. What we want to do, in short, is lift the experience and make this the state, again, where everyone has their goals, values, and preferences articulated and met by the healthcare system. As Atul likes to point out, and I think Amy powerfully reinforced, this is not about a good death. It's about a good life to the very end. And in order to understand a good life, we have to ask, what does a good life mean to you? Now, the theme, which I barely touched on of this section, is now's the right time to change. And I think it is. If we look back even 5 years ago, we now understand the problem better. We have more creative ideas to apply. There appears to be a much stronger will to work together to make sure that everyone gets to express those beliefs and preferences. And a growing number of community leaders, certainly in Massachusetts, but nationally as well, and CTAC is leading the effort, understand and are committed to addressing these issues. When I called and others called, we identified 60 organizations that we wanted to start to form our coalition. And several of the leaders of our effort called them up, and we didn't hear, oh yeah, that's a good idea, we might like to join. What we heard was, I've been waiting. We've been waiting for someone to call us, bring us together, unite us around these issues, and lift all our work together. It was such a reassuring response. And now we're engaged with all those 60 organizations and more who are joining literally every day, so that each makes a specific and tangible commitment to make our goal. You know, I spoke at the beginning, and Amy talked about our professional and personal lives kind of coming together, and I know that everyone in this room has a story, some positive, some probably discouraging, about experiences that they've had with friends or family members or colleagues or patients at the end of life. And it's a lot to think about. But I stood back and said, you know, is the CEO of a health plan, of a health insurance company, the right person to be part of the leadership of such an initiative? I mean, we had just come out of the death panel debate in Washington, and I know that people harbor suspicions of health plans. Are they in these programs to try to limit care? Are they trying to save money? You notice I haven't said a word about saving money. Amy did, and that's great, because we all know in this room there's a lot of possibility to conserve our resources and spend them more wisely. But you know, I'm very cautious about talking about that. And at one point I thought, maybe I shouldn't do it. Maybe I should step aside and let others take the lead and just kind of stand in the background. But then I thought about my experience with my father and my mother and my brother. And I thought also about other big change initiatives that I'd worked on. This is the state, you're in the state, which began the effort to strive to universal coverage for everyone. And we are still the state that has the fewest number of uninsured people. This is the state which has made changing the way we pay for care a priority, and we're leading the state there. When I started working on some of those big initiatives, I sat down with an expert in change. And he had worked on big social change, like the reconciliation process in South Africa, and how do we change the international food supply so that we get food from the countries that have to the countries that have so much hunger. And he reminded me that there was, and we were both old enough to know, that there was a bumper sticker in the 1960s that some of you may remember, which said, if you're not part of the solution, you're part of the problem. I think it was attributed to Eldridge Cleaver, the famous Black Panther. Not sure, but that was And I remember seeing that. And this person I met with said, I think he actually had it wrong. It's not that if you're not part of the solution, you're not part of the problem. It's if you're not part of the problem, you cannot be part of the solution. What I would suggest to you, we're all been part of this problem. As clinicians, as patients, as health professionals, as health plan administrators, as policy experts, as attorneys. And the most durable solutions to complex social problems happen when those involved with the problem create the solution. We're all responsible for the problem. We all can create the solution. I'm so enthusiastic about our ability here in Massachusetts to create a solution that involves everyone and that gives everyone what they want and need. Thank you very much.
Now, good morning, everybody. As you heard from Mark Sterling, my name is Bill Novelli, and I'm a co-chair of CTEC. And Glenn and Holly, I want to tell you how really thrilled CTEC is to be in partnership with the Petrie Film Center. This is just going to be a great and enduring partnership. And Andrew, I want to thank you for your leadership in Massachusetts and for the kind of coalition building and the kind of vision that you're providing. And Amy, where is Amy? Amy, way back there. Amy, at CTEC, we call Amy our national inspiration. So my topic this morning is to talk about building a national movement for change. And everybody in this room knows a lot about change because it's happening to us every day. So the digital world is growing exponentially. People are more informed than ever before. They're just not better informed. There are more channels to reach audiences and stakeholders, but it's harder and harder to communicate. And here in the US, we have all kinds of change. We have more haves and have-nots. This whole change towards social inequality. We have the graying and the browning of America. We have people searching hard for meaning in their lives, in their work and their lives, and they're trying to connect with purpose. And yes, the world is flat. So we're dealing with global ideas and trends and problems. Now, what causes social change and social movements to spring up? I mean, think about it. Well, one thing is crises. Crises cause change. So think of major threats like war, drought, famine, tsunamis, pandemics, economic collapse. That'll cause change. And secondly, what I call those in pain gain. And what I mean by that is that groups on the bottom or in distress get an opportunity and they seize it. Examples of that are civil rights, gay rights, the women's vote way back in the 1920s. And then there's entrepreneurial or heroic leadership. Candy Lightner of Mothers Against Drunk Driving, William Wilberforce, Nelson Mandela are all examples of that kind of leadership. Margaret Mead, the anthropologist, famously once said, "Never doubt that a small group of committed citizens can change the world. Indeed, it's the only thing that ever does." Well, I think Margaret Mead was right, especially if that small group becomes a big group. Ethel Percy Andrus, who was the founder of AARP, called it an army of useful citizens. And then, of course, all of the above, shifting resources and technology and economics and demography cause change. And with the constant that goes throughout all of this is that leadership really, really matters. Now, I want to tell you just for a minute about my early career. I began my career as a brand manager at Unilever. And I worked on laundry detergent and fabric softeners and margarines and toothpaste. And then I moved across town. This was in New York. This is back in the days when Madison Avenue was really hot. And I moved to a big, hot ad agency in New York. And there I worked on kids' cereals and pet foods, both dog food and cat food. And I was making money. I had a family of little children. There was no heavy lifting. But I was having a big problem, and my big problem was I was having a very tough time finding social relevance in all this. And I thought, I need another line of work. And then one day, the ad agency gave me a new account. And it was the Corporation for Public Broadcasting. It was the first time that public television had ever hired an ad agency to build audience. And so the first thing I did was to go to a press conference. So I'm sitting in the back of the room, and there's a woman up there named Joan Gantz Cooney, a name that may be familiar to some of you. And she was saying, we're going to revolutionize pre-K education in America. We've got a new TV program, and it was Sesame Street. And I listened to this woman, and I said, she's talking about education, but she's a marketing person, just like me. And a light bulb kind of went on. I'd had this thought before, but now it kind of solidified. You can use marketing for toothpaste and laundry detergents, but you can also use marketing for issues and ideas and causes. And I concluded from that that's what I wanted to do, and that marketing itself is a very strong discipline to create change. But it's not enough. It's not enough to just focus on individual behaviors. You need more strategies, and you need more power to create lasting social change, especially in the area of policy and legal strategies. Now, I have a favorite haiku, and it goes like this. Problems worthy of attack prove their worth by attacking back. Problems worthy of attack prove their worth by attacking back. Now, what does it take to overcome these big, tough problems that confront us? Well, waiting for change and muddling through are not good strategies. Now, I saw a couple of years ago an article in the Washington Post, and it said that scientists believe there's a bacterium that's eating up the oil from the oil spill in the Gulf of Mexico. And I thought, this would be great. Wouldn't it be great if we had a bacterium to swallow our national debt, to chew up gun violence, to eat other big social problems? Well, no such luck. The story turned out to be wrong. We have to do it ourselves. Now, what does it take to create and accelerate a social movement? And I say that we're doing it right here today in this room. Well, it takes collective efforts from multiple individuals and organizations. We need to form networks and coalitions to spark and spawn a movement, just as it's happening here in Massachusetts. We need to collaborate across sectors, government, the private sector, civil society. None of these sectors are big enough or strong enough under themselves to solve these huge social problems. And we have to achieve and be very clear on a common purpose. Now, what are the drivers of these kinds of social movements and social change? Well, first of all, we need to change the behavior of the public. We just heard a lot about that this morning. Not only do we need to change individual behaviors among people in the public, but we need to get them to support policy change. Why does Washington, why does Albany, why does Sacramento create change? It's because the public demands it. And then we need those public policies, and they are legislative and regulatory and legal, all of them. We need the private sector to be engaged, business practices and policies and pressures and profit. And we need system change. Again, we heard about that. We're talking about changing the health system, or in other contexts, changing the educational system or the workplace. Now let's look at tobacco control. Massachusetts led the nation, Massachusetts and California, in tobacco control. Now the first Surgeon General's report came out in 1964, and it's taken us a half a century to get it right. But now what we have is almost formulaic. We know, was that the tobacco industry? So we know what to do. Here's what to do to control tobacco. Number one, we have to raise the price of the product. This is almost like dose response. You raise the price, adult smoking goes down, and kid smoking goes down even more. Number two, we have to ban smoking in public places. That goes for the government and the private sector. So years ago, one of my clients was the National Cancer Institute. And there was a physician, I won't give her name, who was in charge of a major division of NCI, and she was sitting in a meeting with her people one day. She had a cigarette in her hand, this was many years ago, and she said, "We've got to do something about smoking in this country." So we need to ban smoking in public places, otherwise half of you would be smoking today. We need to educate kids not to experiment and become addicted, because the majority of smokers are addicted before the age of 18. We need cessation for adults who want to quit, and we have to curb tobacco marketing. Some of you are relatively young in this room. You may not even remember the Marlboro Man and Joe Camel. Does anybody here remember when Joe Camel was actually more popular than Santa Claus? So we know what to do. And what we're doing now is gaining the will and the leadership to do it. Now, in order to get all this done, it's necessary to operate at two levels. So think about this. First of all, we have to operate at the environmental level. And we have to make desired attitudes and behaviors normative and expected by changing society's perspective. Smoking was normal. Now it's not. Being overweight and obese today is normal. We have to make it not. Now, there are three main levers to operate at the environmental level, in my view. One is policy, which I've spoken about. One is media, and one is technology. And while that's all going on, we have to also operate at the individual level. We have to change individual behaviors. We have to influence and change people's attitudes and their behaviors through families and friends, teachers, coaches, clinicians, clergy, through knowledge, through skill teaching and learning, usually at community and interpersonal levels. This is not sequential. We have to do the environmental and the individual at the same time. Now, there are big challenges in all this. One challenge is achieving scale. So there's an organization, I'm on the board of it, called Kaboom. It ends in an exclamation point, Kaboom. And they build playgrounds. And for a long time, they had this goal, a great place to play within walking distance for every kid in America. And then they figured out they could do that until they were blue in the face. And they would never achieve that goal. They could build playgrounds forever. Kaboom is a playground building organization. So now they've had to scale up. They've had to figure out how to get cities to engage in what they call playability. Scaling up is hard. Secondly, these issues are incredibly complex. Remember the haiku. These are not easy issues to deal with, and they are not easy behaviors. Third, we need sustained and adequate resources. Now, I remember when the National High Blood Pressure Education Program was a huge success. It was the most successful national public education program in America. And then the National Heart, Lung, and Blood Institute cut the budget to zero and said, okay, we got that done. Now we're going to focus on cholesterol. And today, hypertension is way up. Continuity is important. You know, smoking is really down today. We should have a champagne party to celebrate this. But smoking could very well be cyclical. So now we have e-cigarettes, and we have these damned little cigars that are flavored with licorice and cherry and all kinds of things that kids like. Smoking is cyclical. Everything that we deal with, or much of what we deal with, could very well be cyclical. Now, what does it take to do all this, all the things that I've been talking about? One of the most important is strategy. Do not underestimate the importance of strategic planning and thinking. Reassessment and course corrections. So take the Truth campaign about kids and smoking. For years, there were different strategies employed to try to educate children. One was, don't smoke, it'll kill you. And kids said, oh, I think I'll try that. Another one was, don't smoke, you won't get any dates. Your breath will smell, your hair will smell. Kids didn't care about that. But the last strategy that's been employed has been the most effective, and that is, kids want to rebel. Who do they rebel against? Their parents, their teachers, their clergy, their coaches. Why don't we get them to rebel against the bastards who are selling the tobacco to them in the first place? And that's what the Truth campaign is all about, and it's working. Creativity is very important, including tone and language. Now think about these phrases as important ways to get the public to think in your direction, whatever your direction is. Death taxes. That's a powerful phrase. Marriage equality. That's a powerful phrase. A living wage, a powerful phrase. Now, I remember when I had an assignment, doctor said to me, we want you to educate the public about cutaneous malignant melanoma, and here's what it looks like. So then we went out and did a lot of public research, and we found that the public didn't think it looked like that at all. They had their own set of words and language to describe cutaneous malignant melanoma. Words and language really count. We need evidence-based research and analysis. That's what this partnership is about. You cannot make it up. We need an evidence base. Coalition building is so important. A common cause, shared goals, collective implementation. Policy advocacy, I've already talked about, and that goes for legislative and regulatory and legal advocacy. The media are so critically important. That's why the Conversation Project is so important to all of us. Media campaigns, PSAs, ads, web-based outreach, program content. You know, I'm working on a program right now to get the public to understand better what science is and the importance of both public and private investments in scientific research. And one of the best media expressions of that is the movie The Martian. So let's use everything we can and try to influence the media as best we can. We need high-level visibility. You know, if you're the National Rifle Association, for years and years, you had a champion, Charlton Heston. I mean, for heaven's sake, he was Moses. We need champions. Presidential candidates. Get on their agendas by asking the right questions. You know, at AARP, we used to train volunteers to show up at every presidential candidate's event. I don't care how small it was or how big it was. And what we used to train them to do was ask the third question. So you ask a presidential candidate a question, you get a soundbite. What are you going to do about Social Security? Blah, blah, blah. Go an inch deeper, ask that second question, and now that person has to be a little more forthcoming. And what we have to do is ask the third question. Community level activity is really important. I'm sure they're doing it here, and we need to do it around the country. We're talking about town hall meetings, roundtable discussions, schools, faith-based venues, parents and families gatherings. And then let us not ignore the blessing of good fortune. Teen pregnancy in this country is down virtually everywhere. Does anyone know why that is? The answer is we don't know. We're not sure why. We have to figure it out and bottle it, but it's good fortune. And then, as I said before, leadership, leadership, leadership. Not just from one individual or group, but effective meta-leadership that connects many organizations in a shared course of action. Now let's look at this growing movement that we have here to transform care for people with advanced illness. I was at a conference 2 weeks ago and somebody wanted to talk about this, and he stood up and he said, you know, we're all going to die. Well, some Americans don't agree. They think that it's just kind of like, you know, like an Italian stop sign. It's just a suggestion. But Ellen Goodman of the Conversation Project says the mortality rate in this country is holding steady at 100%. So the issue is not whether, but how we're going to go into the great beyond. And I like to talk about the big gap. So here's the big gap, and we've really heard this morning. So what do people want when they're seriously ill? They want to be at home, as Amy said, in their pajamas. They want to be with their family and their friends. They want to have their pain managed and their other symptoms managed. They want to have their spiritual needs addressed. And above all, number one, they don't want to impoverish or bankrupt their families. And in our wisdom in this country, we give them pretty much the opposite. So we recycle them through the hospital, through the emergency room, the intensive care unit. We give them aggressive treatment they may not understand, and if they did understand it, they probably wouldn't want it. It doesn't prolong their lives, it doesn't improve their quality of life, and then they die, oftentimes in pain and in isolation, in the hospital, at great expense to their families and to the country. And so the question is, how do we close the big gap? And that's what CTAC is working on trying to do. A national coalition working to serve as a voice and a catalyst for this growing movement. But for sure, we are not alone. We're working across sectors with many others, and many others are involved. The Conversation Project, CAPSI, Respecting Choices, the Massachusetts Coalition for Serious Illness Care, and many, many others throughout this country. The strategies center on public engagement, provider and clinician support and education, promoting models that work. And when you think about social change, probably the most important question we can ask is, what works? What's working that we can take and do? We don't want to be reinventors of the wheel. We want to take what others are doing and promote them. And then, of course, policy advocacy. Now, this movement is gaining momentum. Why is that? What's propelling us? What's propelling this movement? Well, number one, in my view, the boomers. So the baby boomers, the oldest of the boomers turned 70 last January. This is a huge population cohort. They've cared for their parents, in many cases buried their parents. The boomers are a feisty lot, and they're not going to stand for what their parents have gone through in terms of advanced illness. The boomers are the secret sauce for us. Number two, the media are covering the issue much better than they have before. A major reason for this is that many of these journalists are boomers themselves. Also, the popular books by Ato Gwande and Angelo Volandes and Paul Kalanithi and others. The Institute of Medicine, it was mentioned this morning by Mark, now called the National Academy of Medicine, put out that report in September of 2014 called Dying in America. A very important report with important recommendations. The new CMS regs, where they're going to pay clinicians to counsel patients and their families on advanced planning. The fact that palliative care is advancing beyond hospitals. National metrics for success are being established so that we can measure progress. And there are a lot of technology startups with apps and other ways for people to get engaged. And then there's a guerrilla action. This is about aid in dying. It just began in California, and other states are involved. This is highly controversial, but it's also engendering conversations. And out of all of this is emerging a common cause, shared goals, an evidence base, collective implementation, and meta-leadership. Now, where is this movement going to go? Well, it's going to go as far as we want it to, as far as we can take it. And what does success look like? Ultimate success is that all Americans with advanced illness receive comprehensive, high-quality, person and family-centered care that's consistent with their goals and values and that honors their dignity. That will be true success. But we have a lot more to do. In areas like community engagement, promoting care models that work, policy advocacy and reform, and that's what the rest of today's agenda is about. Thanks very much.
We have time for a few questions, and Andrew, please come up as well. If you have questions, please feel up with the mic.
I'm wondering whether you're getting any pushback from doctors who stand to lose a lot of money, the people who still use terms such as doctor's orders.
So far, we've not had any pushback. I mean, in fact, the opposite. First of all, to acknowledge and to reimburse physicians, excuse me, for conversations they couldn't have before has been a positive moment. I actually think that most doctors are also victims of the same system. They get caught in this cycle that Bill described in the ICU and et cetera. And so we've actually had kind of been embraced by physicians. And I would add that, part of the growing movement is the palliative care movement. And I think the more physicians who are educated and trained in that, the more success we'll have. Although one group we haven't talked about is how do we kind of think about medical and nursing education differently in the future.
Our experience is exactly the same. We've had no pushback from physicians. Physicians didn't sign up to torture patients. They want to do the right thing. And one of our key partners, I would add, is the American Hospital Association. And there's not just no pushback there, but they basically are agitating for change as well.
Hi, my name is Iris, and I'm a manager for a small acupuncture clinic in Needham. And my question is, we get a lot of seniors who come looking for acupuncture services because acupuncture is really good for providing pain relief and reducing anxiety. But sometimes we have to turn them away because Medicare doesn't cover acupuncture, and neither does most Blue Cross plans.
Yeah.
So I'm just wondering, you know, as a small provider, what are ways that we could join this movement and maybe try to push for more coverage?
Yeah. First of all, I agree with you that acupuncture and other complementary medicine can play a key role. What I'm hoping for is that over time, as we start to move away from paying for individual services and paying for the health of a group of patients, that primary care physicians, who are really the locus of that payment, will start to use alternative or complementary practitioners because it supports their work in keeping the patient healthy and out of the hospital. So it's probably not a short-term solution for you. We do have a network of discount acupuncturists and others, and if you're not in that, you should explore joining that, because then our members get a discount when they go for it and encourages them to sign up.
Thank you.
Okay, here's the big question, I can tell.
Lachlan Faro, a palliative care doctor at Beth Israel Deaconess, and I chair a Mass Department of Public Health Council on this. So, thanks, Bill, for the summary of the vision about this should be true in the future, but Andrew knows what the question is going to be. 10 years from now, what are the 1 or 2 outcome measures that we have systematized so that we know whether what you're happening is true or not? And Andrew knows that I think that's surveys of family members after death, asking them 2 or 3 simple questions. Was your loved one always taken care of the way they wanted, or other things? But what are the 2 or 3 outcome measures that 10 years from now are going to be telling us how we're doing, and how are we going to get those outcome measures mainstreamed?
I'm going to do half, but then I'm going to let Bill, because I think it was more directed to Bill. But all I should say is that in the larger question, so the quality measurement field is evolving, and we've made a lot of progress in measuring other domains and aspects of care, including outcomes. This area of how do we get better quality measures around care at the end of life is just in its early stages, and our coalition plans to address that as part of our work. But let's see what the national answer is.
Where'd the questioner go?
He's way back.
Oh, we need your help. Dr. David Longnecker is here. Where is David? There's Dr. Longnecker right there. So he's leading our work with the National Quality Forum and others. And what's going on right now is they are basically establishing the metrics that you're talking about. So what will they be? Place of death, length of stay in hospice. I mean, there are a whole bunch of these different things. What we hope to do is to have this work far enough along to talk about it at our national summit in September. But the very metrics that you're calling for are being worked on now.
Go ahead. Yeah.
I hope you can hear me, but indeed, all day yesterday was devoted to a national meeting, National Quality Forum, Flame Tree, a patient advocacy group, and CTAC as co-leaders of exactly the question that you asked. What are those proper domains that we need to measure, and what are the key measures that will tell us whether we're making progress? Not 50 measures that we get lost in the weeds, but a few of the key ones. I'll share just one that I like, but I'm not suggesting that would be it. But where do people die? Amy started by telling us that 70% of people would propose that they prefer to die in the home. What they experience is 70% die in the hospital. Now, choices may change over time, obviously, depending on the extent of your illness. But those kinds of big measures that will, with just a few, you could address to know whether we're achieving that national goal is something we're working very actively on, literally every day through CTAC and several other organizations.
So, two questions.
Thank you for the opportunity to make a question. My question is on suffering. Nature of suffering change over time toward the end of life. And toward the end of life, the pain that comes from the loss of meaning and also social cycle nature of pain increase. But before that, we can have to address some scientific pathways of the pain. We have a lot more to do. And is there any way to more integrate the some social scientific understanding and more spiritual understanding of the pain?
Yeah, it's a great question. And I would say generally, and there are experts in the room who know this better than I do, we probably overtreat the medical aspects of serious illness and end of life, and we undertreat the social, psychological, spiritual, and kind of family aspects. And I think my experience is that the best palliative care recognizes that and treats that, and part of treating the whole patient and the family is focusing on the social, psychological, and spiritual aspects of care. And so I think we need to do more research in that, and I would turn to people like Lachlan and Vicki Jackson, others, some of who are going to speak later, to perhaps they could address that in their panel.
My name is Alice Howard. I'm a Cambridge resident and an alumna, 2 schools here at Harvard, and a volunteer for Compassion and Choices, which is a national organization that supports medical aid in dying. And you spoke about it being a guerrilla movement, and probably one of the page turners for all of what people care about in this room was the publicity of Brittany Maynard in California, who moved to Oregon to be able to choose medical aid in dying. Very quick question for you, Bill Novelli. Would you support Compassion and Choices and Death with Dignity as 2 organizations nationally that support aid in dying as being members of CTAC and having a place at the table?
Well, first of all, if I offended you by calling it a guerrilla movement, I'd be happy to call it something else. Give me whatever phrase you choose, and I'll use it in future. Secondly, CTAC does not support aid in dying. We have taken a totally neutral position on it. And our reason for doing so is that we found that in many places on the Hill, with certain religious movements and other places, that the controversy is extreme. And I'm sure you found this in your own work. So as we see the world, we've got a large agenda that we want to deal with. And we have a concern that if we were to really align ourselves or take a position on aid in dying, that it would, in essence, interfere with the larger agenda. So that's the position we have taken.